Thank you, Marcia. I just want to say thank you to our church for putting this on and for asking me to be a part of this. I know a lot of you in the room. My name's Liz Brown. I'm a social worker. I do currently work for the VA, so I'll be sharing some of that information towards the end. But most of my experience is in geriatrics and hospice care. So much like Mike, whose work often, unfortunately, centers around what happens when things don't go well and we haven't prepared. Most people don't need a social worker if things have gone really well and we've been prepared, right? So I have a lot of stories about what happens when things have gone awry, and I'll try not to share too many of those with you today. Many of you may know me as Aaron and Wyatt's mom. As moms, we get that title right. And some of you know me as Bob and Katie Franzen's daughter. And so I have had the unfortunate experience of very suddenly and unexpectedly planning things when someone has died. My dad was unfortunately killed in a car accident when he was 55 years old. So I can attest that if you've had some of these conversations ahead of time, especially about funeral, what a gift that is to your family. So I'm going to talk a little bit today about how to prepare your families for some of these topics, because we've talked a lot about task-centered, functional things that we need to do today, right? There's paperwork stuff that needs to be done. But you knew that as a social worker, I was going to talk to you about your feelings. We love to talk about our feelings, right? If we do all the functional stuff, but we haven't had the important conversations with the people that are going to be involved in some of this process, you would be amazed at how things won't happen the way you wanted them to. And that's when people like me get involved with your families and get in the middle of conflict. So first, I'm going to start with just a really brief video from a resource called the Conversation Project. So this is a website that's available to you. It has so many resources to help you facilitate these conversations in your families and your faith communities. I'll show you some of those resources. It's totally free. I don't work for these people, but it's a really great resource. theconversationproject.org is where I'm going to get this video from. So, Stephen.
Finally tonight, ABC News.
So we've talked about the importance of a few key topics, and I want to just build on those a little bit, and I'll leave some time for questions as well. So when we talk about who's going to be there at the end and who's going to make decisions for me if I can't make them for myself anymore, it's really critical that you've thought about who's the right person. You can appoint anyone that you trust to be your durable power of attorney for healthcare decisions, but have you had that conversation with those people? You'll notice on durable power of attorney for healthcare forms, there's no place for that person to sign. And so as a social worker in the hospital, I've had the really fun experience of calling someone to let them know that, Mr. Jones is in the hospital and we need for your assistance. You're named as his healthcare power of attorney, and it's time to start making some decisions. And the person on the other end of the phone had no idea that they were put in that position. So that's why I say the paperwork's important, and so is the conversation. You may be appointing someone who knows they've been appointed to make decisions for you, but they have very different values and very different ideas on some of these topics. And so before we start filling out paperwork, we want to make sure to have a meaningful conversation about what matters most to you if you were at a life-limiting or life-ending diagnosis. And so having those conversations is just as critical as the paperwork. And the conversationproject.org has a conversation starter guide, and it asks some really thoughtful questions that you may not think of on your own, and they can kind of spur the conversation. So I have an advance directive, I have a durable power of attorney for healthcare, and I have a living will. Full disclosure, will be 44 this month. As far as I know, I'm in good health, but I'm not a magical unicorn. And so life can happen to me just like it happens to anybody else. This information is important for adults of all ages. My 21-year-old son has a durable power of attorney document, and it names me. Because if something serious happened, I can't just swoop in so easily anymore as mom and take care of things. So this has nothing to do with your age, and it has nothing to do with your health status. This is about being prepared, okay? So I want to share a couple of resources that I have for you as well. Some of these will apply to you, some may not. I'm going to hang back as long as people need me to afterwards. When you're having these conversations, when you go home from here and you do your homework and you're talking to the people in your life about some of these decisions, you can say that you attended this session and this social worker told you that you had to. So that's a really good way to start the conversation, is to blame me for an uncomfortable conversation, because I'd rather you have it now than to wait. So first and foremost, durable power of attorney for healthcare decisions. I brought with me a basic form that's accepted at all of our hospital systems. It has a power of attorney, and it also has a healthcare treatment directive on the back. I have a bunch of copies, and you can take a look at those before you leave here. Obviously, if you're doing any in-depth estate planning, my guess is that any reputable attorney, such as Mike Crow, is going to include that as part of that process. Please don't delay, but also if you want to look at those forms, I have one with me. I also have with me what's called a TPOP form. That's a transportable physician order of patient preferences. This is basically a DNR form, but it goes across state lines and it travels with you, whether in your home, in an ambulance, in a hospital. And if you want to take a look at one of those forms and talk it over with your physician, I highly recommend that you do that. We often don't talk about CPR outcomes for folks based on age and health status. Only your physician can do that. I encourage you to force them into an uncomfortable conversation. It's called we call it a TPOP because you know how we love acronyms, especially, I work for the federal government. We love an acronym. It's a transportable physician order for patient preferences. What I like about this form is that it gives some nuance, so it doesn't just ask you black or white, CPR, yes or no. It has some nuance included about, well, maybe in some situations, or maybe how do I feel about comfort measures, things like that. I'll let you look that over and review it with your physician. But as Mike was explaining, if we have not completed a DNR form, if you want to be a do not resuscitate, which means you want to allow a natural process to take place at the time of your death. If you want that to happen, you have to have a form that is signed by your physician in your home or wherever you're living. You may go to the hospital and you tell the doctor while you're in the hospital, I wouldn't want CPR if my heart stops. That order by that doctor only applies to that time while you're in that hospital. You need to have a form like this that travels with you. Or when 911 is called, by law, emergency responders will come to your home and they will be required to do absolutely everything they can to restart your heart. Some of you know my husband is a police officer, and he has had to do CPR on people that there was no business doing CPR on those people, but it's because they had a living will that said their preferences. Your living will is a declaration of what you want to have happen, but by law, when emergency responders get there, they're not going to dig through your legal paperwork or your living will necessarily. They want to look for this form signed by a doctor. It's an order, okay? So this is a really important part of the process. My living will says that Liz Brown, age 44, in my current health, I would want you to try life-sustaining treatments for me for a time. I believe I could sustain CPR. I could sustain a trial of being on a mechanical ventilator. That's me at my age and my health status. When I'm 90, you better not. You better not. And I will have a DNR at that time, okay? Go. Thank you for asking. So, I dropped my pen. It's my favorite pen. I don't want to lose that. So it travels with you, meaning that when you're in the hospital, you might have a DNR order on file at the hospital for that episode of hospitalization. But say you live in an assisted living facility, and there is some type of transport that's going to take you from the hospital to your assisted living facility. What happens when your heart stops and you're in transit? Are you a DNR? Not unless you have a form like this signed by a doctor. When you get home, I've worked with people in hospice at the very end of their life, and they did not have a DNR form. And so therefore, we would have to do CPR on someone who technically is admitted to hospice care. Fun fact, you can be admitted to hospice and be what we call a full code. That is your right as the patient to make that decision. I would personally say that's not advisable, but when people haven't prepared, we haven't had these conversations, and now your daughter has to make that decision. I've seen family members struggle and insist that we do everything for mom. I know she's on hospice, but when her heart stops, we have to try. And so then we're doing CPR on a 97-year-old, 100-pound lady. Please don't let that happen to people that you care about. Go ahead, Dr. McAllister.
So assuming that you're interested in being an organ donor and you're willing to go on life support long enough for them to harvest your kidneys, do you talk to a social worker about how to do the paperwork so that's possible?
Absolutely. And as Mike said, the living will form that he included in your packet is a very sufficient document, but you can also attach additional pages as long as they're, appropriately signed and witnessed along with that original page that gives nuance to your circumstances. And so you can include information about organ donation. You may also include in your living will information about cultural, spiritual, religious, faith-based values that could impact your medical treatment. So your living will documents can be really basic, or they can be really individualized. And you can work with an attorney to assist you with those things. In the hospital, I assist people with that every day. It's my full-time job, so that's absolutely something that's an option available. Go ahead.
You checked off the organ donor thing on your driver's license. How does that work?
Yeah. So if you're in a circumstance, most often this is how this is going to happen. I'll just bring it down to brass tacks. Organ donation typically is an option when you're in a hospital setting and we know you're preparing for end of life and decisions are being made about withdrawing life-sustaining treatments like mechanical ventilation, tube feedings, et cetera. And so the medical team is going to talk with your family about organ donation. And so any documentation you've done to give them that guidance about what you would or wouldn't want is very helpful. Also have these conversations ahead of time. I also regularly have folks ask me about, could I donate my body to science? Has anybody here ever wondered about that? I've had a family member to do that. That is something that you also need to make arrangements for ahead of time. KU has what they call their willed body program, and you can elect to do that. There is some paperwork you would need to do ahead of time, and if people have individual questions about that, I can talk with you about it after. Keep in mind that if you are doing body donation of any kind, you need to have a backup plan, because at the time of your passing, the university can elect to decline your anatomical gift at that time if they don't need it. So you always want a backup plan. Sorry, I didn't mean to get so into the weeds about things, but I could talk about this all day, honestly. And the reason that I talk about this, and I talk about it at length with people, is because I'm also, as Mike mentioned, on the ethics board for the VA healthcare system in this lovely area of our country. And most of our consults, or our complex cases that we get, are cases where there is conflict around these exact issues. Maybe dad had a living will, but now his 2 adult kids are in conflict about whether they want to follow that living will. And so we have to get involved in that, because dad filled out the paperwork and never had the conversation to make things real clear. So I can't emphasize that enough. And when you're thinking about who you want to entrust these decisions to, what character traits are you looking for in that person? Who's going to be there? Who's going to make those hard calls for you? This is not a rhetorical question. What character traits are you looking for? Shout them out. Honesty. Character. What was that? Wisdom. Empathy. What was that? Being brave. Yeah. Compassion. Yeah. Pragmatic. Okay. Methodical. Available. Yeah. There's another good one. Y'all don't pick your 18-year-old grandson who never answers the phone, please. Yeah, exactly. Think about the character traits. I also want you to think about who here has 2 or more children in your family? Okay, 3 or more, 4 or more, 5 or more? Okay. Don't name all your children as your decision makers, please. I think people oftentimes think about, when I'm naming my power of attorney, I don't want any of my kids to feel left out or feel like I didn't trust them enough. And ultimately, when you name all 5 of your kids as a durable power of attorney for healthcare, I now, as the social worker, having never met them before, have to get 5 people in a very emotionally stressful time to all agree on a really hard call. It's not likely that that's going to be an easy process, and we're trying to avoid conflict, guilt, fighting at end of life, right? And so please don't name all 5 of your kids. What I always tell folks is, all of your kids can be involved in the conversation. Everybody can be in the room and be a part of the talk, but we need you to appoint 1 or 2 hopefully, because you always should have a backup, who are going to be that decision maker. Okay, so think about who's the right person, and it needs to be somebody who can make a hard decision, somebody who knows my values, someone who can use what we call substituted judgment, which means you're not going to make the decisions. I need my healthcare decision maker to make the decisions in accordance with what I would want and my values, not necessarily how they would feel for themselves. They need to use substituted judgment in that situation, okay? We do have power of attorneys for healthcare. We do have those decision makers routinely attempt to override your decisions in the hospital. And it's not because they don't care about you. It's not because they're being disrespectful. It's because they love you, and it's really hard. So think about that ahead of time. Who's going to be able to make the hard decisions, and also who is going to be available for when that moment comes. Does anybody have any questions? Thank you, Marcia. They do not have to be physically present. Sometimes I hear people say, well, I want to name my daughter. She's a nurse. She's really capable. She's really in line with my values. She knows what I want, but she lives in Maryland. I don't care. We'll call her on the phone. We do virtual video conferencing in with the physicians. The most important thing is pick the person you think is best. I've had to use the Red Cross to contact a service member who's deployed. If I can do that, I can call your daughter in Maryland, okay? Pick the person you think is best. Their physical location does not matter. They do not have to be related to you by blood or by law. Good question. Thank you. So when should you complete a power of attorney for healthcare decisions or a living will? Yesterday. Yesterday. Did you drive here today? Yesterday. Oftentimes I get referrals from physicians, from primary physicians that say, hey, I've got this patient and his family really needs a power of attorney. He's got such severe dementia. I can't help you. It's too late. You have to have the capacity to make those decisions for yourself. So please do not wait until an event has occurred or a disease has progressed so far that now I ethically cannot allow you to sign anything for yourself. Now we're going to go to court. Go ahead. Do they time out? Great question. So your power of attorney for healthcare decisions and your living will are valid until you take steps to tell us otherwise. You can revoke them or change them anytime that you want to, but you need to make sure that they stay up to date along the years, because whatever document is the document that we have, that's the document we have. So they don't expire, but you can change them anytime you want to. Good question. Did I answer that question? Okay, thank you. Go ahead. The T-pop? Mm-hmm. Yeah. Mm-hmm. Sure. So he was asking about the difference between the old sort of, it was like a pink-looking form that has, are you talking about that, like the outside the hospital DNR form? Yeah. So this form includes information about CPR, but it also gives you the option to say, I want you to attempt CPR or do not attempt CPR, and then also additional treatment orders that can say, I want full CPR, full everything, or you can say selective treatments. And that could be positive airway pressure, antibiotics, IV fluids. It also gives the option to say, I want comfort-focused treatments, so pain medications, anything to keep me comfortable. I do want you to utilize those. So there's more individualizing the document. It's not just about CPR, because there are a lot of other, as Mike was saying, medical technology has advanced. We can keep you alive for so long. And CPR is just one of those interventions. Good question. Jan?
Can you put on there if you have allergies or negative responses to narcotics?
Absolutely. I recommend that on your documents, like a TPOP form, a durable power of attorney, a living will, those documents, it's really important, as Dave was saying, to have things like that and your funeral planning, all that in a location where people can easily access them, and information about allergies, adverse reactions, and your medication list. It's really good to keep all that together, because when the ambulance comes to your house, if they can grab it all and take it to the hospital, it's extremely beneficial. Good question. Go ahead.
You can put it on your refrigerator.
Yes. Yes. Most people will keep if they have a DNR form, they will keep this on their refrigerator. Emergency responders know to look on your refrigerator. I've talked to people that say, you know, when my grandkids come over and grab a Twinkie from the freezer, I'd really rather them not see my DNR on the fridge. Understandable, right? Keep it in a plastic sleeve in your freezer. And emergency responders, there's just this unknown rule that we look in your freezer. Mm-hmm. Got a question? Red file. Excellent. Yes. So the Council on Aging has what they call the Red File Project, and it's kind of a transparent red file, and it's magnetized, so it sticks to your fridge, and you can put things in it like advanced directives, a DNR, your medication list, all of that, and stick it to your fridge. Yeah.
Where do you get that form?
The T-pop form, I have a whole stack of them. I'm happy to hand them out like candy. What a fun thing, right? Yes. Also, Marcia asked me to mention that I'm also a notary, so I do help people with these documents every day, and so I'm also a notary. Other resources that I'm going to have at the end that might not apply to everybody in the room, but I have a feeling quite a number. I have resources from the VA about application for burial in a national cemetery and what we call memorial products. And also information about applying for VA survivor benefits as well. So I'll have those with me afterwards, as well as the power of attorney and healthcare treatment directive forms, the basic forms that most of our hospitals use. And I also have a booklet here that's about setting healthcare goals. And I have a whole stack of them. I encourage you to take a look at one if you want to take one with you. It asks about the benefits and risks of lots of these treatments we're talking about: mechanical ventilation, CPR, tube feedings, dialysis. I know we have a lot of medical folks in the room with medical background, but some people don't have that. And so we might not even understand what some of these treatments mean. And what happens if I say yes to a feeding tube? What happens if I say no to a feeding tube? Those kinds of difficult questions, we've got that information in these books. It is from the VA. I'm not here on official business, but this is such a great resource for anybody, so I brought a whole bunch. Question, Kristen?
Yeah, is there a way to set it with a lot of these documents that you have a primary person and then a secondary rather
Yes.
than two people who are making a decision together?
Yes, good question. So Kristen asked, is there a way to set this so that you have a primary decision maker and then an alternate so that we don't have two people making the decision together? Yes. So I have a primary healthcare decision maker, and then I also have a backup. And my backup is only called upon or given that authority if my primary person is unavailable or refuses to participate. We have that happen sometimes. We think somebody's going to be able to make those tough calls, and then when the moment arrives, they are uncomfortable, and they always have the legal right to refuse. So you can name somebody. It doesn't obligate them legally to actually follow through. So a backup is important. If you're naming anyone that lives with you, if you're naming a spouse, really important to think of a backup. I have my husband as my primary decision maker, and we tend to be in a car together a lot. On a motorcycle. Sometimes I let him fly me in a plane. If something's happened to me, he might be banged up too, and we saw this a lot during COVID. Spouses or people who live in the same household all got really, really sick together, right? And so an alternate is important. Question?
I always worry about this. I gave it to the Providence because I was having surgery down there. But when I talked to St. John's, they asked, we can find it. Should I give it to St. John's?
Good question. What do you do with these documents once you've completed them? So Providence and St. John, she mentioned like, if it's on file with Providence, is it on file with St. John? They're technically owned by the same healthcare system, so their medical records talk to one another, but that's not the case with all hospital systems. So your advanced directives are going to be good in any hospital setting, but how are they going to know you have one? You put one on file if that's a place where you regularly get your health care, or you make sure that people in your life in an emergency have quick access to the documents. So when I do advanced directive documents with people, you keep your original and we make extras. Put a copy on file at your local hospital if you're most likely to be taken there in an emergency. If your daughter's your decision maker, give her a copy of the documents so that she can get it easily when she gets that call and has to run out the door. Okay, so make sure people have copies of these documents if needed. Go ahead.
They told me to put it in the glove compartment.
Yeah, some people keep a copy in the glove box of their car.
That's what they
Yeah.
That's one place.
Mm-hmm. Yeah, absolutely. Other questions? Go ahead. Yes, and we will accept electronic copies of those documents, and most of the time, those sticky situations only get sticky when people in the family are fighting. So, thanks for asking. I've had people say, oh, well, you know, the doctors are just going to want to pull the plug on me so fast. You know, that's what they're going to want to do. They're going to want to free up that bed. They're going to want to free up that ventilator, right? Right? Have you known a doctor? All due respect to the physicians in the room, but most of the doctors I've worked with want to believe that they can fix it and they can make it better, and they'll try everything. So it's usually the opposite. It's usually your friendly neighborhood social worker who has to come in and say, hey, maybe we want to take a time out. Yeah. Yeah. Your doctor's not going to be quick to pull the plug. That's not going to be the person. Yeah. Yeah, we'll try everything. I have so many stories I could share with you about situations like that. I'll share one. So I had a patient who I was working in a long-term care setting, and this is many years ago, but this patient was incapacitated, unable to engage with his environment in any way, unable to communicate, and unable to have any voluntary movement, couldn't even like reposition himself in the bed. It didn't appear that he had any ability to engage cognitively with his surroundings, and his body could breathe on its own. He didn't need a ventilator. Those basic functions of your brain can keep your body alive a long, long time. But he couldn't safely eat or drink by mouth, right? Because if you can't wake up and talk to us, it's not safe for us to feed you by mouth. You'll choke. So inevitably, we have to have conversations about feeding tubes. And he lived in a bed, fed through a tube, with his diapers changed for many years. And he had one family member who would come to see him very occasionally. And he also had a significant source of income. And that money was continuing to be deposited in his bank account every month. And because of his veteran status, he had a certain level of eligibility. This doesn't apply to all veterans, but he had a certain level of eligibility that said his long-term care bill was paid by the VA. And so all of his money was still his to keep, and all of his monthly income was still his coming into that bank account. Who do you think had access to that bank account? Oh, the family member who visited occasionally, and ultimately was the person who got to decide how long do we stay alive on a tube feed in a bed, unconscious. Now, here's what I'll tell you. From my standpoint, and this is because of my personal values, I said, oh my gosh, when I got hired and I was working there, I thought, does this man want to be kept alive this way? Would he want this? We had no direction, no documents, no evidence to say that he'd ever talked about these things, certainly never written anything down. Okay, so his decision maker was his next of kin, which was this family member. And I personally had a values conflict with what was going on here, right? Like, it's very uncomfortable. And then I had other people who came from a different background than I did, culturally, different socioeconomic background, who waited and said, maybe this guy would be okay with this. Maybe this patient would be okay with this because he knows that every month that he is surviving, he is helping to provide for his family. Right? Maybe there are nieces and nephews, maybe there are grandkids that we don't know about that are being financially supported by this income, and he felt that if that's the least he could do, and that was his purpose, was to help financially provide for his family, maybe he would be okay with that. That was a value of their family. Maybe they had a family that had grown up in poverty, and this person had been the financial backbone and supporter of their family, and that was important to him. Could be, right? I hadn't thought about it that way. Sure would have been nice if I had anything from the patient indicating that, because then I would have felt a little bit more comfortable. But ultimately, it's not about my comfort, right? It's about that patient, their dignity, their values, what matters most to them. The only way we can know that is if you let anyone know that in advance, and please document it. So what happened? Yeah. I'll just be honest. I won't go into details because not everybody here's medical and comfortable with those things, but medically there are some really unfortunate things that can happen with a human body when you leave it in a bed that long. Okay. Yeah. I've had the opportunity to be with people in the very final moments of their life, and many people as they took their last breath, and I've seen things happen in a very dignified and peaceful and loving way when family is prepared and conversations have happened ahead of time. And I've also been in households where people are actively in conflict and stress and such duress in that moment because we haven't talked about it. Often when topics are uncomfortable, and maybe they may make us want to cry or feel afraid, our brains want to protect us from those negative emotions because it says danger, and so we back away from those topics. We're protecting ourselves, right? Our brain says danger when we feel stress, fear, anxiety, worry, guilt, what we call anticipatory grief, meaning I'm already starting to grieve, I'm afraid of what's coming. Right? So we pull away, and I urge you to lean in those difficult emotions and not to back down from seeing when you bring these topics up with your loved ones, you may be well prepared to have these conversations and feel like, I'm okay with having this talk now. I'm at a place in my life. I've had a good life. I know what I want, what I don't want. I'm ready for the conversation. And then you see someone you love start to cry because you bring up the topic. Has anybody had that happen? Okay, some raised hands. I'm ready to have the conversation, but they're not. Allow people to have their hard emotions and to cry and to feel some anxiety about these topics. It's because they love you, but it doesn't mean that the conversation doesn't still need to happen. And so blame your friendly neighborhood social worker who said, hey, we've got to have this conversation. Use the resources from the conversationproject.org. They have literal conversation starter guides if you have a hard time finding the words. Any other questions? I'm sorry, go ahead.
Do you know anything about the difference between hospice and palliative?
Hospice and palliative care. Thanks, Marcia. You're like a plant. We didn't plant her there, but she's so good at this. Yes. So palliative care is a term that's used in hospital settings to acknowledge that somebody has potentially a terminal or life-limiting illness, and they need additional support to help them live the best quality of life that they can, while they may also still be receiving active and curative treatments. That's palliative care. Hospice care says we're no longer pursuing curative treatments for whatever is going on, and we've decided to focus on comfort. And so we're no longer pursuing active treatment for things. We are going to focus over here on comfort. And a physician has to state that if your disease process were to run its normal expected course, you would have 6 months or less. That's hospice. Hospice is not a place or a company. It's a type of service. It's covered 100% by all insurance, including Medicare, and there's no out-of-pocket expense to you or your family. Hospice service can be provided in a nursing home setting, an assisted living, in your home. So hospice is a type of care that focuses on comfort and dignity and preparing you for your death. But it's not a place or a certain company. There are lots of companies that provide that type of care. I think there's like 80-something in the Kansas City area, so there's a lot of options. But hospice covers things like durable medical equipment. Do you need a hospital bed in your house? That is covered by hospice. What about a bedside commode, a special kind of lift to help you get in and out of bed? Any medications related to your comfort, medications for pain to help you with breathing easier. Do you need oxygen for comfort? Hospice provides oxygen, not a mechanical ventilator breathing for your body, but supplemental oxygen, sure. Incontinence supplies, which can be really expensive at end of life. All of these are covered at 100%. There's no out-of-pocket expense, and hospice should not be for your last 3 days. I've taken care of patients that I met yesterday. They don't have much of a relationship with me, right? They don't even know who's there taking care of them. I don't have a relationship with the family built up yet when there is like extreme moment of crisis. If I could have met you several months ago, we could have built up a trusting relationship. The whole experience is different. Hospice early, I say. It's a wonderful service. Thank you for asking. Debbie.
But when Jim was on hospice, we were told, once you're on hospice, you may not call 911.
Correct.
Call.
Right. Medicare is going to pay for hospice or the hospital, not both. So that's a Medicare coverage issue. Hospice is when you've decided you're not going to the hospital and seeking aggressive treatment anymore. And so we have to be prepared to make that transition from calling 911 every time it seems like mom's breathing's getting weird, we need to call 911. No, you don't. You have hospice. Call your hospice company. They're supposed to come to your home and help you there. Go ahead.
What happens, my father-in-law ended up being on, it's not gonna happen today, but ended up being on hospice for 3 years because it just worked out that way. But what happens if you live past the 6 months and they were wrong?
So if you live past the 6 months and they were wrong, happens. You can be recertified for hospice as long as they can document to your insurance a progressive decline of your disease, then you can be recertified. So I worked with people on hospice for longer than 6 months. Also, sometimes people graduate. People do, they graduate from hospice. That happens. They stabilize. Sometimes when you bring in a whole interdisciplinary care team of supportive people, you get better, right? What a wonderful thing. We graduate them, and then if they need us again, we come on back. Yeah, that happens. Good question. Yeah. Okay. Any other questions? Okay. I appreciate everyone's time. I'm going to hang back. Oh, Miss Jan Glick, yes.
My question before was, does the VA offer?
Yes. So if you are a veteran, or if your loved one is a veteran, all veterans that receive care at the VA have a social worker assigned to them. You might not know that. You can't swing a dead cat at the VA without hitting a social worker. We're everywhere. Sorry. I don't know where that saying comes from. So there's a lot of social workers. Every primary care provider and specialty provider, doctors, nurse practitioners at the VA have a social worker assigned to their team. And so if you don't know who that person is, if you get your care in Leavenworth, then you can go to the C1 hallway at the Leavenworth VA. Down the hall where there's eligibility, release of information offices. It's on the emergency room side of the hospital. We've got social worker offices lined up. Just walk into any one of them, and we'll be happy to connect you with your social worker and talk about how to facilitate all of these things in terms of like VA side of the house. Go ahead, Jan. Miss Jan Glick has known me since I was, I think, in the 6th grade. So you can ask me all the questions you want.
Would they put on some sort of seminar like this for people who don't use the VA regularly, but so that we know who to call, whatever?
Sure. So I should organize that? Okay. Excellent. Excellent idea. Yes, I love it. I think the VA side of things can be overwhelming, and so I have some basic information and resources for folks today, but ultimately I agree there's opportunities for us there, right? As the spouse of a deceased veteran, you can come see us anytime, and we'll be happy to talk with you. Yeah. There's a lot of information that veterans and their spouses don't know about their burial benefits, all kinds of stuff like that, and we'll be happy to help. Go ahead, sir. You cannot pick out your plot, like your specific place, but that is a benefit that's available to you. Veterans can be buried or cremated and have their ashes buried or placed in a columbarium, like a big memorial wall. And you don't necessarily pick out your particular real estate ahead of time. We probably wouldn't have picked out the real estate my dad got assigned, frankly, but it's beautiful. It's beautiful up there, but we really got to walk up a hill. Katie's going to have to stay in good shape to keep walking up that hill, she always says. So you don't necessarily pick out this specific spot, but you do have a place there for you and your spouse. A lot of people don't know spouses can be buried with you. Also, certain situations for dependent children also. And I have a bunch of information about that